Thank you very much, Chairman. My name is Kyungyeon Kim, working at Gangnam Severance Hospital. Today, I'd like to talk about the prediction of mechanical complications after adult spinal deformity. Current update. Rather than current update, I think it would be better to summarize the important factors for preventing these complications. I want to memorize this as ABCD. Here is my disclosure. Mechanical complications happens frequently after adult spinal deformity surgery. There are multiple reasons such as UIV level selection and insufficient cell star balance after surgery, and bone mineral density, and patient residence or lifestyle could be one of important factors for it. Today, in this presentation, four important regions associated with mechanical complications could be summarized. Number one is alignment, like ideal lumbar lordosis and lordosis distributions, and gap score. Number two is bone quality and BMI. Number three is circumstances, uh, which means their lifestyle or residence. And prevention when mechanical complication happens, at least we have to avoid a serious complication such as paraplegia. For analysis of alignment, we have to know about the concept of carnal economy and the importance of a pelvic vertebra, and we have to know about the Russelli classifications for determining the patient's original curve. Based on Russelli classifications, we could assume the appropriate inflection point or ideal lumbar lordosis according to pelvic instance. This article reported from their retrospective multicenter study of 290 adult spinal deformity patients with regard to instance of mechanical complications according to Russelli classification. Their proposed algorithm is to restore the low pelvic instance patients to type 1 or 2 while restoring high pelvic instance patients to type 3 and 4. 22.5% in the proposed algorithms have mechanical complications, whereas the remaining 34% of patients which was no proposed algorithms group showed 46.8%. And restoring the shape according to PI decreases by threefold the rate of mechanical complications. So in case of high pelvic instance over 50 degrees, correction of sacral slope to reduce pelvic tilt is always should be done distal areas. If we do make increasing upper arc of lumbar lordosis, we have to make a rebalancing proximal junctional kyphosis. There are so many theory and equation for ideal lumbar lordosis. For me, half pi plus 28 is the easiest to remember. It's very simple. Usually, ideal lumbar lordosis is almost equal to pelvic instance. However, just alignment correction is not enough to explain everything, because elderly people usually have osteoporosis and sometimes high BMI. So if we make perfect alignment post-operatively, mechanical complications could happen for this kind of patients. We published these articles in the Spine Journal at 2020. And we compare our GAPI scoring system, which is BMD, PMI combined with GAP score, to other scoring systems such as Schwab age-adjusted model and GAP score itself to predict the incidence. Using this nomogram, including BMD, PMI, GAP score, we can calculate the probability of mechanical complications. And the results showed that CAPI scoring system is the best for prediction of mechanical complication. Circumstances such as rural or urban lifestyle after surgery are very important factors, especially in East Asian country. According to our articles about this matter, rural patients have higher rate of mechanical complications, and it might be caused by lower volume of multifidus and erector spinal muscles. This patient lived in rural area. She underwent deformity surgery 7 years ago from L1 to S-12 iliac screw. After surgery, she never gave up her farming with severe bending postures like this picture. So eventually PJK happens and UIV screw loosening also happen. And so we decided to remove UIV screw and distal broken iliac screw. And after that, her pain was significantly relieved, but sagittal balance was worsened. Finally, recent my personal choice of UIV fixation is hook, and I will tell you the reasons. In adult spinal deformity, usual location of UIV are spinal cord. I think pedicle screw at UIV level makes facet violations and precipitate the hypertrophic degenerations. As all we know, thoracic facet joints are coronal orientations and widely cover the spinal canal. Thus, the hypertrophy of a facet joint means thoracic myelopathy because there are spinal cord. So after corrective fusion surgery like this with UIV pedicle screws, and we have to follow this patient very closely. Then she visited the ER for rapidly progressive paraparesis due to myopathy. So you can see the disc herniation and facet joint hypertrophy and myelopathy around the spinal cord. So we did second time revision surgery, and we use proximal transverse hook for this patient. According to these articles, who could not prevent PJK or PJF compared to pedicle screws, I agreed with these results. So this patient have coronary sagittal malalignment before surgeries. And so nowadays, I always use proximal hook at UIV level like this. So, so far, no one suffered from myelopathy or paraparesis after this kind of UIB fixation method. For prediction or avoiding mechanical complications after adult spinal deformity surgery, first, sufficient and harmonious sagittal coronal realignment is very important, and we have to consider patient with poor bone quality, and we can modify this patient preoperatively with teriparatide or romosozumab. In case of patient with a rural lifestyle, preoperative counseling about losing their quality of life, such as sitting ability after multi-level fixation, should be discussed. Finally, it is if it is inevitable sometimes, we have to prepare some techniques not to make the serious disasters. Thank you very much.